So like Deanna mentioned, my name is Kim Thornhill. I'm a care coordinator with the Toronto Central LHIN. The acronym for the LHIN is Local Health Integration Network. And my background is that I'm a physiotherapist. I started working with what was then the CCAC, or the Community Care Access Center, in November 2015. And I work on the adult supportive care team, which is adults 18 to 64 with complex medical, social needs. Are you guys familiar with the LHIN overall in general? Okay, so I'll just give a brief background. So in Ontario, there are 14 LHINs. The LHIN that we are in is the Toronto Central LHIN. Our borders are in the north, the 401, so Wilson, York Mills. In the south, all the way to the Toronto Islands. In the west, in some areas it's the Allen. In other areas it's Islington. And in the east it's Victoria Park. So we cover most of Toronto. Anything north of the 401 is the Central LHIN. And they go all the way to Newmarket. And then we're bordered by the Central West LHIN, which is Brampton area, the Central East LHIN, which is Scarborough, Mississauga Halton LHIN. So we're surrounded by lots of other LHINs as well. What do we do at the Toronto Central LHIN? So we plan, fund, coordinate, and deliver services to citizens in Toronto. So this is across 17 hospitals, including rehab and complex continuing care hospitals, 59 community agencies, which of you guys are many, 36 long-term care homes, 22 service providers, 17 community health centers, and 75 community mental health and addiction services. So really, when you think of the LHIN, it's not just home care. It's lots of different sectors. So we also partner with lots of community organizations that don't directly have to do with healthcare or care provision, but they intersect with what we do. So some of these may include the Ontario Disability Support Program, the Assisted Devices Program, lots of other different kinds of government programs. And we provide care in lots of different settings. So people's homes, their apartments, their condos, shelters, group homes, retirement homes. Some services we do provide in nursing homes if it's specific, such as speech and language therapy that may not be available on site. So we really do go anywhere. Even if people are in temporary housing like a hotel or something like that, we try and provide as much service as we can where people are. So together with all of our partners, we help to support clients and families in their community to be as healthy as possible. We try and improve their experience in the healthcare system, and we try to ensure that we're using our healthcare dollars in our system to make it stronger. So this slide is basically just showing that within Toronto Central LHIN, there are approximately 1.3 million citizens navigating across all of the different sectors that I just mentioned. 60% of the care that we deliver in Toronto Central LHIN is actually for people that reside outside of our LHIN. So that's for people that may come into Toronto for specialist services in hospitals, health centers. So for example, if you had cancer treatment at Princess Margaret Hospital and you lived in York Region, you would come down into Toronto. Let's say you needed nursing services when you're ready to go home for IV treatment. We would process that referral and send it off to that Central LHIN. So a lot of what we do is processing referrals and services for people that actually live outside of our LHIN because of the specialty nature of all the hospitals and health centers that are here. So this slide also shows that for some clients and families and individuals, it may be challenging trying to access one of these programs and not knowing how to access services across these sectors. So a lot of times people get connected to us through maybe an admission to a hospital or through their family health team. And it can be confusing to clients and families because they may not know that we do a lot of different things or that we try and help them navigate the healthcare system. So this traditional model of operating in silos is what we're trying to get away from. But it can be challenging because we've been operating like this for many, many years. This is, again, just speaking to the same thing. The fragmented nature that can be accessing healthcare services. So at the bottom you may have family and caregivers, and they may be accessing any one of these sectors, and along the way there may be barriers in the way. So it may be that they need to go to their family doctor in order to get a referral to a specialist, or to get a referral to an outpatient program like a rehab program, and they may not know how to navigate all of that. So that's where a lot of the challenges are coming in, is just that we're siloed. So some of the feedback that Toronto Central LHIN citizens have told us is that they want better access to services and programs, and they want to stay at home. They need help with navigating and coordinating through the healthcare system and to the community system. And communication with all of their different providers, their physicians, their specialists, can be challenging, and that's often an area where we try our best to help support clients, because it can be overwhelming. A client may have several specialists, they may have a home care provider coming in for PSW, personal support worker, they may have an occupational therapist from another agency, they may have a social worker from this agency, they may have a wound clinic that they go to. So a lot of the times it's navigating all of those different sectors. So this is a quote from a Toronto Central LHIN resident saying, "I don't care how you organize my healthcare or about the rules. I just want it when I need it, where I need it, and I want to feel confident that it's going to make me better." Okay, so this slide is just highlighting again the borders of our LHIN. So like I said, the Highway 401 area in the north, Islington in the west, Victoria Park Avenue in the east, and then we go all the way to the Toronto Islands. So we have coordinators that will go out on the ferry and see clients there for home visits. I think it was last year or the year before when they had a lot of the flooding, that really did affect a lot of the client care because the providers had to figure out other ways of getting to the clients. So we do navigate around some challenging situations as well. Within the Toronto Central LHIN, there are 4 sub-LHINs. So we have North Toronto, which is a large chunk of North York. We have West Toronto, Midwest Toronto, Mid-East Toronto, and East Toronto. So the middle slide here, the middle part of the slide is just highlighting the Midwest section of Toronto. And then the last section here is just highlighting, for example, the Moss Park area. So they did a lot of population-based studies to see, particular to this neighborhood, who's living there, what's the age group, is it older people, is it immigrants, is it mostly families, what's the client population, different demographic factors like what languages are spoken there, different types of cultures that are there. And they also looked at income. So what was the mean average income? They looked at health conditions particular to the Moss Park area. So they found higher rates of things like diabetes, COPD. They had a higher incidence of individuals going to the emerge. So we're trying to figure out why does this happen in this particular sub-region. So looking at population-based data helps to strengthen local partnerships because you can better plan if you know what population you're serving. Understanding what this population needs, constantly reassessing the quality of services that we're delivering, and helping to strengthen alignments with our care providers and the different agencies in that geographic area. This slide just highlights basically that individuals can access various parts of the healthcare system. So it may be a provincial service, like a hospital. It may be a regional service that may be only available to some clients. So if it's specific to like a children's hospital or a cancer care hospital, they may access a regional service. And then local services would be a lot of the organizations that you guys come from. So on a local level, a lot of the home care agencies and community health centers, community agencies that clients can access. Okay, so instead of that, the second slide where I showed the siloed areas of how we're operating across the different sectors of the LHIN, this model is what we're hoping to strive for. So you have clients, families, and caregivers trying to access the healthcare system at different levels. So it may be at the hospital level, home care level, or it may be through a family health team or a physician. And in the middle is care coordination. So we're trying to help clients to navigate across all of these different sectors, and we're also trying to share information between the sites. One of the things that individuals and clients asked us was we need one phone number where we could call and know where we can get help. So we have our main number at the Toronto Central LHIN, and there's a lot of services and supports that we do provide, but if we don't provide that, we definitely can give them the information on where they can access the service. So that was one thing that clients wanted to know was, I don't want to call all these different agencies, I just need to know where I can get the help. So that was one of the things we continue to strive for. Are you guys familiar with coordinated care plans at all? No? Okay. So a coordinated care plan is what we develop in partnership with clients. It could be with their family health team, it could be with their service providers. Whomever is providing a service to that client, we gather them all in one room. We develop goals with the client, and then we determine who's going to help with what. So it's an accountability tool for everybody, for the client, because they can have something tangible where they can see, okay, this is what I'm striving for, this is what I'm working towards, and this is what I need to do. And then it also gives us an idea of which agency, which community service is helping with what. So coordinated care plans are really a collaborative approach, and they're constantly being updated. So it's not a stagnant tool. So once a goal is completed, you may take it off, or you may add a new one. With our coordinated care plans, we're sharing them with different providers. So not only can we as a care coordinator update them, but the service agencies can update them as well, and we get those updates. So that's part of how we're trying to kind of navigate all of the different healthcare sectors, but also make it more integrated and sharing information across. Okay, so in home and community care, we provide health care and supports to people so that they can continue to live safely at home. We assess clients and listen to what's most important to them. We are often the first point of contact for long-term care homes and government-funded home and community care. In 2017, we started the process of merging the CCACs with the regional LHIN, and in 2018 we officially became one. So the CCAC took on the name of the LHIN. So people still call us the CCAC, which is okay because that's what they know. When that merger happened, there was not really any changes at all to service provision for clients or to care coordination. It was a merging of two organizations, and it was more so changes at the upper management level. So really our client care, frontline care wasn't affected at all. Okay, so at the Toronto Central LHIN, we have several different programs. We have our palliative care team. So with that team, we partner closely with agencies or community services such as Tammy Lattner for clients that are near end of life. And we have the adult supportive care team, which is the team that I work on. So that's adults 18 to 64 with complex medical or social issues. We have our seniors care team, which is one of our largest teams, and that continues to grow. So we provide services to clients 65 up to the hundreds. We have our child and family team. Some of you may be familiar with some of the coordinators on that team if you're working in that sector. We have acute rehab and transition team. So this is for clients that may be accessing services through our agency short term. So let's say you had a surgery and you had a wound and you needed short-term nursing at home, you would access our acute team. Or if you just needed occupational therapy for a home safety assessment or prescription of a mobility aid, that would be a short-term service. We have our urban health team, which is clients with mental health issues and addictions. And also we serve a lot of clients that may be homeless. And then we have our hospital transition team. So we are embedded in all of the hospitals and rehab centers in the Toronto Central LHIN. So that's to help facilitate discharges from hospital back into the community. So oftentimes some of the clients that you may work with may get referred to the Toronto Central LHIN after they've had an admission to a hospital or a visit to the emerge. So they may be triggered that way. That's where a lot of clients do come in. In terms of making referrals to the LHIN, anybody can call us. So it can be the individual themselves, it can be a family member, it could be a community support worker, it can be a physician's office, anybody can refer to us. So you would just dial our main number and you would get connected to our call center. That number is 416-506-9888. So part of the intake process is that you will speak to a team assistant and explain the situation. And they will help to navigate and see if you need to speak to a coordinator in our call center. And then once you speak with the coordinator in the call center, at that point, you tell them your situation as well, and then they will start to see, okay, what services and supports can we provide? Some services we put in quite quickly, and other services we may need to transfer the client to a community care coordinator that would go out and do a home visit. So some services we can put in right away and some are a little bit delayed. Okay, so who do we provide care to? So we provide care to over 73,000 people across Toronto. So that's a lot of Torontonians. One of the other stats that I noted that was quite interesting was that we provide care to 22,000 people in Toronto Central LHIN a day. And then annually, we transition about 56,000 people from hospital setting back into the community. So we really are, as a LHIN, in all different areas. The types of clients that we help is really anybody from newborns and infants all the way up to 100-year-old clients. So it's pretty much everybody. We help seniors, younger people, not only in the home setting, but also if they need care at school. So we're in the school systems as well. We help patients needing to find a family physician. I don't know if you guys are familiar with the Healthcare Connect program. You've heard of that program? So it's a government program where if somebody does not have a family doctor, Healthcare Connect will help to link you to that family physician. The one caveat is that you have to be de-rostered from your previous family physician, or you have to have no family physician at the time. And they will help to find you a family doctor in your local neighborhood. So usually the first visit is like a meet and greet, where you get to meet the physician, they get to meet you, and you decide if you feel like this is going to be a good partnership. And then if it is, then you roster with that particular physician. If it's not, then you come back to Healthcare Connect and they try and match you up with somebody that's a better fit for you. So that's another aspect of home and community care. We're trying to make healthcare more local so that people aren't having to go way out of their neighborhood to find their primary care physician. Okay, so as a care coordinator, we do a lot of home visits with clients. So part of it is doing comprehensive assessments to determine what the client's health and social services needs may be. We develop care plans with clients, we set goals, we coordinate care and services, and we help them navigate the system. So my job is if the service that the client needs is not something that we provide, I try and help them navigate to that particular agency that may be able to provide the service that they need. We communicate the care plans not only to the service providers but also to physicians, because oftentimes they may not be aware that their patient may be on home care services and what exactly those home care services are. And we're constantly evaluating the benefits of the services provided. So we do frequent home visits, we do follow-up assessments, and we remain involved throughout the care process. Okay, a large part of what we do is also long-term care placement. So we have a long-term care placement team at the LHIN that's responsible for carrying out all of the requirements of the legislation in terms of equity across applying to long-term care. We provide applicants, families, and caregivers with information about long-term care placement. We assist with the entire placement application process. And then we also prioritize admission to long-term care based on the client's need and their situation. Our placement team monitors and manages the wait list for all the long-term care homes in Toronto Central LHIN. And in the other LHINs, it would be the same thing. They would each have a placement team that would manage and monitor the wait list for long-term care. We provide education to we provide education supports for hospitals and community coordinators and placement-related questions. We provide counseling on difficult placements. So placement can be difficult for a variety of reasons. Oftentimes, from my experience, it could be potentially behavioral symptoms that a client may have. That can often be a barrier. It may be smoking or substance use that also can be a barrier. There's lots of different reasons why a nursing home may look at an application and see, okay, I don't think this person may be a good fit, and it's our job to see how we can negotiate with them and see how we can better manage that client's needs so that they can get into a safe place. We provide extensive knowledge of the different long-term care homes and some of the specialty services and support some care homes will provide. For example, not all of the care homes have a secure unit for people that may be at risk for wandering. There's only specific homes in the city that have dialysis. So there's or they can accept clients on BiPAP or other things. G-tubes, those are other specific care needs that only certain homes can manage. Within the long-term placement team, we have long-term care, we have short stay respite, and we have convalescent care program. So those are the three main programs, and they all come under long-term care. Okay, this last slide is just highlighting nursing clinics. I'm not sure if you guys have any clients that have accessed any of our nursing clinics across the city. Okay, so when this presentation was made, there were 3 clinics at the time. We now have 9 clinics across the city. So at these nursing clinics, clients and individuals can have access to quick and easy specialized nursing services. So you can see IV therapy, chemotherapy disconnects, which is really awesome because clients don't have to go back into hospital for those services. Advanced wound care, injections, ostomy and catheter care. And they also do a lot of teaching to clients and family there to how to manage their own care at home. Our nursing clinics are managed by nurses and they're by appointment only. So people can't just walk in and be seen. One of the really good things here is that the appointments are booked in like 15-minute increments and they keep a tight schedule. So it's really efficient. You can go in, get your treatment, and then go about your day, as opposed to maybe having to wait in a family doctor's office for long periods of time or things like that. Or waiting on a nurse to come to visit you at home, that kind of thing. Our clinics are open 7 days a week, most of them 8 a.m. to 8 p.m. and on the weekend until 4 p.m. And we have clinics all across. So we just opened a clinic at Yonge and Highway 401. That's brand new. There are clinics. So we have a clinic at Women's College. We have a clinic at Storefront Humber, which is on the lakeshore. We have the North Nursing Clinic, which is at Eglinton West, close to here. Do you know where Pine Villa is? It's just east of Oakwood, on Eglinton there. That's one of our nursing clinics. We have Lansdowne Community Clinic, that's a new one. And we have a Sherbourne site, so 410 Sherbourne Street Nursing Clinic. So some of our nursing clinics are already embedded into community health centers. So for example, the 410 Sherbourne Street site is embedded into that family health team site. The new clinic in the north is embedded into Closing the Gap. I don't know if you're familiar with that agency, Closing the Gap Rehab Express. So they provide lots of different services. So we're really trying to partner with different community agencies that already exist instead of reinventing the wheel. For clients trying to access these clinics, it's for people that are ambulatory and transportable. So if you have a client that is not meeting those criteria, then they wouldn't be able to access the nursing clinic. So as long as the client is able to safely transfer, either independently or with the assistance of a caregiver or a family member, then they can access the clinics. Unfortunately, at this time, they don't have like Hoyer lifts or ceiling lifts. So for clients that may need those types of mobility aids to transfer, they wouldn't be able to access the clinic at this point in time. Any questions so far? Okay.
Sorry, just about the nursing clinic.
Yeah.
So with the coordination of that and the referral, so is the assessment made by the LHIN to determine whether a person gets the care at home? So even if they would prefer the care at home, if they're ambulatory and they fit all the criteria, they would go to the clinic?
So we're really trying to, that's why we've also created a lot of different clinics across the city so that people can access them in their neighborhood. So if you are ambulatory and if you're able to access the clinic, there are certain exceptions. So let's say the client may be at high risk for falls, or they may be at risk for immune compromise. Like there are definitely exceptions to certain situations, but we try our best to try and link clients to their local nursing clinic for that care. It really is more efficient than having nursing service in the community, but there are exceptions, and there are clients who may not be able to access the clinic for one reason or the other.
And if they've been assessed as being able to access a clinic, and their status changes, how difficult is it to get them?
Not difficult at all. We would just reassess the situation. So oftentimes it may be the nursing clinic staff that may call us and say, you know, this client's situation has changed. It might be mobility-wise, it may be medically where it's not stable or safe for them to come and access the community clinic anymore. So we would flip them over to other maybe in-home nursing or something else. Yeah, so it's not a complex process. Okay. Yeah.
I'm wondering if you have any nursing clinics out of this area, so for example in Oshawa?
I'm not sure, because that would be in a different LHIN. That would be in Central East LHIN, so I'm not sure. But if you go onto the Central East LHIN website, they may have that information, or you could call their LHIN and they would be able to tell you. But for sure, in the last 2 years, like we started with 3 clinics, and we, as a LHIN, we're really trying to ramp up the amount of clinics that we have. The the East Office Nursing Clinic on the Danforth, that's closed only because that location, they're going to be tearing down that site and building something else there. So we're in the process of finding another location in the east to offer service to clients.
Will you be talking a little bit more about closing the gap at some point in the presentation?
Sure, I can take a question. It's okay.
Well, I want to know what is it that they provide, because
have you heard of them before?
Yeah, a little bit.
Yeah, so we have different service providers that we work with. Most of the services that are offered through the LHIN we don't directly provide. So we partner with Closing the Gap, and that agency will often provide physio service in home, social work service, speech and language therapy. Those are the 3 main ones. We have other agencies like BHA that may provide personal support worker service, but they also are contracted to provide occupational therapy service, some physiotherapy service, and dietitian. We have other agencies like St. Elizabeth Healthcare, Circle of Care, CBI Home Healthcare. We have a lot of different service providers. Some of them are geographic specific, but those are the big ones. So we work with lots of different agencies. Any more? Yeah.
Would those services be covered under OHIP?
Yes, so all of our services,
Even
as long
like
as you have an
physio?
OHIP card,
Right.
they're covered by OHIP. What was I going to say? Oftentimes clients' health cards are out of date, so that's one of the things that we help with. When we go in and do home visits, we try and see, is your health card up to date? Why not? Sometimes people have the old card and they prefer the old card. It might be that they can't get out to the Service Ontario, and then we figure out with the family doctor the way around that. There's a form that they can fill out so that the client doesn't have to go in, or they can access. So it may be good for people who are homebound. If accessibility is an issue, there is a workaround for that. So, yeah. Any other questions? Okay. The last slide is just basically showing if you want to learn more information about Toronto Central LHIN and what we do, you can go online to the website and learn some more information. Specific to what I do, my area is most of North York. So my area is Bayview to the Allen, St. Clair-ish area. So this area, Eglinton up to Wilson, York Mills. So in my area, it's quite interesting because there's quite a few group homes. So I have clients that live in group homes from RENA, and also clients that have support workers where they live independently in the community, but the support worker comes and visits them and helps them with their banking and groceries and those kinds of things. Bob Rumble is also in my area, and I have Christian Horizons, one of the group homes, yep, and I'm missing one. Lena, Christian Horizon. Oh, Carrie's Place. Yes. So Carrie's Place at Lawrence and Mount Pleasant. So a lot of my knowledge and learning around services and supports for people in the developmental sector has come through literally doing home visits. And usually if I do a home visit with a client that may have an intellectual disability or a developmental disability, I try and meet them either with their caregiver, with their parent, with their support worker, with the group home team lead. We really try and partner with you guys because oftentimes you have a lot of information that we may not get from the client, either because they may not know or they may not be able to tell us. So oftentimes I learn about what you guys do through home visits. So I was recently telling Deanna that I wasn't aware of the Designated Control Acts program, and I learned that through meeting Angie Gonzalez and learning about that program. So oftentimes, as the LHIN, we may not know what's out there, but usually if I learn something, I try and share it with my team. We have people come in and do in-services, so Angie came in and did an in-service about that program, because that's really how we learn and we partner better. So, any questions?
What kind of service does the PSW could offer to our client? What are the stuff that they could do beside personal care, for example?
So our personal support worker service is focused on the personal care. So showering, dressing, hygiene, toileting. They can help with light meal prep, which is things like preparing a sandwich or a drink or opening a can of soup, those kinds of things. Unfortunately, we don't have housekeeping. So oftentimes if clients need to access a housekeeping service, we may refer to homemaking nursing service. We may refer to a local agency like Sprint or Reconnect or one of those agencies that can provide support. There used to be a really good agency called Saints. I don't know if you guys are familiar with them. They're in North York area, but they were a student organization that was pretty good. So really the focus for the personal support worker service is on the personal care.
So when you were talking that you could help client with banking and these kind of stuff.
So that we don't do, unfortunately. But we would link to a support agency that might be able to offer that type of assistance. So part of what we do in care coordination is if we don't provide that service or support, we try and link you to that agency or support. So sometimes for clients that may be having difficulty with managing their finances, we may look to family, or we may look to, if we think capacity is an issue, we may look to getting them a capacity assessment through the Ministry of the Attorney General. A capacity assessor can come out and do a formal assessment to see if that client is capable of making those types of decisions, and if not, they'll designate a public guardian trustee. So oftentimes when I'm going into a lot of the group homes, a lot of clients already have a public guardian and trustee for property and personal care decisions, which is really good. And sometimes they don't. Sometimes there's a gray line between getting consent and capacity from people within the developmental sector that I've noticed, not just for accessing healthcare supports, but also for things like consent to move into a nursing home, those kinds of things. In terms of long-term care, some of our clients within the developmental sector do access long-term care sooner than the general population. It could be for a variety of reasons. Mostly it's because of their healthcare needs can't be managed in the community anymore, or it may be that there's no availability within the developmental sector in a group home or other setting, and there may be caregiver burnout. I have clients where they may be, in their late 50s and their parent may be in their 80s, and something happens with the parent and then a crisis happens. So oftentimes that can be how clients access us, because it might be a community provider like one of you guys who calls us and says, okay, this person is in a crisis. So specific to the developmental sector, we often get,
Sorry,
no,
go
it's
ahead.
okay, it's okay.
I just, what about training we have community clients who go into either a group home or a respite setting,
Mhm.
and the support staff need training in G-tubes or diabetes, blood glucose testing, insulin.
So
things
if
like
it
that.
can be, oftentimes if it can be taught to a client or a caregiver, we will try through our nursing service. So it may be that person could access a clinic and they can be taught in the clinic by nursing staff there. Or if they're not able to, it may be in-home nursing service, and that can be taught to, a caregiver or family member. Specific training for delegated acts would be, I would say, through the Delegated Controlled Acts program.
Okay.
I would encourage you guys to access that.
Delegated control acts.
Is Deanna, do you know the full name?
RHPA, Registered Healthcare Professionals Act.
Right.
Yes.
RHPA.
Yes. I only recently heard of this program, like I said, through Angie, but it's really awesome because they have designated nurses that may come into the group home setting, or they have set up where all the staff can come in and be trained. And it's not training the trainer. Each staff gets that individual training.
That's through the Network of Specialized Care?
Yes.
Okay.
Yes.
How
So
is
that-
it called again, the program, sorry?
RHPA, Registered Health Professionals Act. Right.
Yeah, the acronyms.
The acronyms.
Specialized Care. And
Do you guys know
Jennifer
Angie?
Yeah.
She would be a good reference point as well, because she actually came to our team meeting and did a presentation for us about that. So
We
she.
have training modules for our
Yes.
staff. But it has to be concluded by a nurse that it is a controlled act.
Yes.
If it is a controlled act, then our staff can be taught to do
Yes.
it. If it's not a controlled act, then nursing staff must come in to continue that
Yeah.
procedure.
So I know for some of our clients, they're getting nursing visits for insulin administration and blood sugar check. That would be.
And some of our staff are allowed to do that, but it has to be something that it's controlled. Like,
Yes.
It has to be predictable and that it's something that they need on a regular basis.
Yes. Yeah. Intermittent catheterization is another
Correct.
other one.
Now, there is I believe that they are looking at possibility of training again down the road for staff to do that as well.
Mm.
Possibly, there's a pilot.
Oh, very cool.
There's a pilot, I don't know the
Okay.
status of it because it began about a year ago and then I've heard nothing.
Okay.
We're often asked, in my location, we had someone who was capped for 3 times a day. He has unfortunately recently passed away, but we were being asked by the nurses, well, can your staff do it? And I'd say, no, we can't. It's not a controlled act yet.
Mhm.
There is a pilot, but I don't know if it's
Okay.
But we have a lot of that because we have an increasing aging population.
Yes, for sure. Definitely it is possible. So to your question, staff could get that training. Yeah.
Can you just talk a little bit about the supports you provide for children in school?
I'm not as, to be honest with you, I'm not as familiar because that's a separate child and family team. But I do know that we have occupational therapists that go in, physiotherapists that go in. Usually the schools have social workers that are assigned, so not as much social work, but for clients that may need equipment in the school setting, they may train staff on positioning and exercise programs, things like that, how to transfer clients, those types of programs. OT does a lot of early intervention around handwriting and that kind of thing, the learning setting. They do have dietitian and PSWs that go in, so for clients that maybe have higher care needs, they can access those programs as well at school. So for clients that may need toileting, dressing, those kinds of things, high care needs, there is PSW that is available in the school setting as well. But I'm not as familiar.
Okay.
Yeah. But we do have our child and family team care coordinators that would be experts in that. So if you had a specific question, I would say to call the main LHIN number, and they can probably connect you with one of the coordinators on the child and family team if you have a specific client or question. Yeah. Any other questions?
Yeah, it's in regards to PSWs coming to the home.
Yeah.
I've heard from several parents that oftentimes PSWs don't show up, and then it's either, they were either called in sick that day, which is, everybody calls in sick once in a while, and that the agencies are not able to backfill those hours. And then the other concern is that if a person gets an hour and a half of services, the PSW will come in and do a half an hour of work and then leave. So is there?
It could, so to answer your first question, some of that is just the nature of home care, and it can be difficult to plan because we're not an emergency service. So we like to say to clients, have a backup plan just in case. So oftentimes PSWs do get sick and they call in last minute and say, I'm sick that morning, and your visit as a client, let's say they're calling in at 7:30, your visit might be at 9. So the turnaround time for that PSW coordinator to come in and find a new PSW is quite tight. So there are times where the PSWs may not show up as scheduled because there may be a reason, and there may be a time when they can't fill that visit. But what they will try and do their best is to find a replacement PSW, and it may not be at the time that your original visit was. It may be later that day, or it may be using that hour or hour and a half another day during that week.
We've been told that that's not gonna happen, so.
Within the week they can, so
If
as
they
long
can
as
find
it's,
somebody.
if they can find, if the agency has that availability, if they don't, then unfortunately it can't be filled, but the agencies do try if they can to find PSWs to schedule later in that week, but sometimes it can be challenging. In Toronto, there is a high turnover of PSWs, so as fast as the agencies are training new PSWs and bringing them on, they have PSWs that are leaving. So often that can be a bit jarring for clients because they may get used to one PSW and then that PSW is gone. So we try and educate clients as best as we can that yes, you may have an assigned PSW, but be aware that there may be a time where that PSW may not always be with you. I know it's hard because people develop that relationship, especially for clients in the developmental sector. Routine can be very important, and we try, but there are circumstances that are beyond our control. Your second question was?
In regards to
if they were assigned an hour and a half,
Mhm.
the PSW may only stay in the home for half an hour because they're just focused on the physical, the personal hygiene piece.
Yeah.
And if that's completed, then they're like, well, I'm out of here. And
So that might be, so if a particular parent is having that issue, I would encourage them to contact their care coordinator, because that can be something.
yeah, they've done that
And it
several
didn't-
times, and it's just, they're supposed to call in and call, like when they start and clock out. But I think the coordinator had said that there wasn't much that they could do. It's almost like, they can go to their next appointment sooner and then they finish their day sooner. So
Okay.
oftentimes
They're in a rush.
they're in a rush to get out to go to
Yeah.
their next appointment so they can finish at 2 instead of 4 o'clock or whatever,
Yeah.
right?
Yeah. So those are things that I would
And
definitely.
I think because of the shortage of PSWs, agencies aren't really pushing for the workers to, finish
Yeah.
their hours because,
Yeah.
they're kind of scared.
Yeah.
Yeah, they're scared that they're not gonna show up or that
Yeah,
they quit.
and sometimes they can be stretched, so sometimes PSWs can have large geographic areas that
Yes.
they cover, so it does happen. It should be an issue though that can be worked out with the provider and the coordinator and the client and family. It could be that it might be you have to switch to a different provider. Sometimes I have clients with 2 different providers. If one provider can't fulfill all of the visits, we might have 2, which can be confusing to the client because there's 2 different agencies coming in, but that's one of the workarounds that we do, because sometimes some clients have really high PSW hours, or they may have, for the clients that attend school, time specific is gonna be important for them because they have to catch the bus. So, mornings tend to be the busiest times. Weekends tend to be the hardest times to find a PSW. Just to be honest with you, it's just the nature of home care. Those are things that we're aware of and we're trying, but it's a constant struggle. It's a constant struggle, yeah.
Do you support families in kind of creating a backup plan, planning for the event that especially a morning PSW wouldn't show up? I have some families who, where they rely on that support for one
Yeah.
individual in the home and the others actually have to leave for work at a certain time, so.
Right.
Yeah, just the planning.
We try to, in the sense that it might be, and some may not be reasonable. So some families may be able to afford to hire a private caregiver to fill in if their regular PSW is away, but that's often not possible. There are other community agencies that do provide attendant care. I don't know if you guys are familiar with Centre for Independent Living Toronto, SILT. So it's a program that does offer 3 different types of programs. So they have supportive housing. So it would be an apartment building that would have accessible apartments. And the providers are going to be like Pace, Bellwoods, March of Dimes. All of those agencies have supportive housing throughout the city, and they have attendants on site. So throughout the day, the attendant would go up and provide care as needed to the client. The caveat for that program and all of the programs through Centre for Independent Living Toronto is that you have to be able to direct your own care. So you have to be able to tell the attendant what you need help with.
Doesn't apply for children though, it's just adults.
No, it's just adults.
Yeah.
Yeah, I'm not as familiar with the supports in the, with children and youth, but if you call our LHIN and you ask to speak to one of the child and family coordinators, they can definitely give you more resources. So this is for adults that are 18 and older. There's direct funding. I don't know if you guys are familiar with that program. That's really awesome. So it's where the government will give you a chunk of money and you can hire your own caregiver as long as it's not your family. It's a really awesome program because the client is considered the employer, so they can find their own caregiver, they can set their own schedule, they can have care at home and care in the community. So I have a client that attends York, so she gets services, attendant service. Her attendant comes with her to York and helps her with her personal care there. Again, you have to be able to direct your own care.
That's through the SILT program again?
Yes. So in terms of directing the attendant, they accept all kinds of communication, nodding, blinking, a communication device, speaking. So as long as you can tell somebody what you need help with, you know, and they service clients who are on vents, clients with trachs, clients who may have suctioning needs, G-tube, really complex clients.
So how
that's-
do you get this funding?
So you would apply through the Center for Independent Living, so you can find the application through that website. The first part is you fill out the application, you send it in, and then usually approximately 6 months later, if the client is ready, they would go to a site and have the direct funding panel do an interview with them. So in that interview, it's really a negotiation. So the direct funding wants to see that the client knows what supports they need, who helps them with what their schedule is, because it's really a negotiation to see how much funding you're going to receive. They also provide funding for people who need care overnight. So whether you need positioning, toileting, suctioning, they do provide that overnight care too. Built into the cost of their program is a bookkeeper. So for people that may need help with that aspect, they can hire a bookkeeper to help them with the payroll. The last program that they have, so it's supportive housing, direct funding, and then the last one is outreach attendant care. So that's providing attendant care to people in their home setting. So similar to a personal support worker, they would come and visit you at home and help you with primarily your personal care. But there are some agencies that may offer specific services. So Spinal Cord Injury Ontario can do a lot of the different catheter care for clients. They can also do like rectal stimulation and those types of specific tasks that they're trained for. And also with that program, you have to be able to direct your attendant. So that agency is really good because they offer those 3 different types of programs. The supportive housing wait lists are really long, and they prioritize clients that are in highest need. So for those clients that may need frequent visits, overnight care, they're trying to prioritize those clients, as opposed to if you may have an individual that may not have that much care needs, they're not going to get into housing anytime soon, probably, yeah. So that's often what we'll look at as an alternative. We also look at private pay option. If families or clients can afford to hire a private caregiver, that's always an option as well, to supplement our personal support worker service. We partner with lots of different agencies. Sprint, in my area is Sprint, Loft, Reconnect, Downsview Services for Seniors, which is now called something else. I forget what it's called. Lumicare. Lumicare, you guys are familiar? Yeah. So we often partner with those agencies as well. There is something called the Toronto Seniors Helpline, and they call it the Seniors Helpline, but it's for people, it could be adults with disabilities as well, so it's not just for seniors, but they just call it that. And that is a service where you can call in clients, family members, physicians can call in, and if you need help with, for example, mowing your lawn, or housekeeping, or you want to attend a day program, or you need a private caregiver to go to medical appointments with you, they can link you to various service agencies in that geographic area where you live. So that's a really good resource, the Toronto Seniors Helpline.
But those are fee for service? Like
Some of them are. Some of them may be programs that may be subsidized, but a lot of them are. They can do Meals on Wheels referrals, those kinds of things as well. And if you call them, you give them your postal code, and they'll look up what supports are available in that area. So it's really good so that you don't have to really do all of that work yourself, because it can be daunting trying to figure out who's out there. Any other questions?
I have a question.
Yeah.
So can you tell us a little bit about what's going on in your political landscape in terms of changes that might be here down the pipeline?
So separate from whatever the ministry is doing, because
Yeah.
unfortunately we don't have a mandate yet. So I can't tell you, like I was explaining before,
Yeah.
I can't tell you what their plan is. As well, I'm not very high up on the chain
Food
of,
chain.
so usually we hear things quite later down the road, similar to when the public does. So One of the things that the LHIN is trying to do, separate from all of these things happening, I was mentioning before, is organizing into neighborhood teams. So the slide I showed about the subregion, so as care coordinators, we're being realigned into neighborhood teams. So for example, I'm going to be in the Lawrence Anglемount team, which is basically west of Bathurst to the Allen, just north of Eglinton to Wilson. I'm going to be working with complex clients. So complex for whatever reason. It could be medically complex or socially complex. My caseload is going to be a little bit smaller, so I can spend more time with my clients. But also, one of the things that we're expected to do is partner better with family health teams, family doctors, community health centers. In my area would be Unison. Prior to that, Ann Johnston Health Station was one of my areas. So it's really partnering with service providers and hospitals in that area to try and provide better care to clients. So that's one shift that we're doing, and it's happening right now. So all of these, so you may be familiar with care coordinators with the LHIN. Don't be surprised if your client may get a new coordinator, just because everybody's shifting. But care in terms of service provision has stayed the same. So it's just a change in care coordinator. So that's one of the internal changes that's happening right now. We continue to go on as normal. So until we hear otherwise, we just keep going. We keep doing our care coordination, we keep doing service provision. That's all we can do. Yeah. So unfortunately, I don't have a lot of answers. But when we do, there certainly will be messaging that will come out. We just don't know what that is yet. So we may all probably learn at the same time, unfortunately, or fortunately. But yeah.
Not to put you in the hot spot either again, but sometimes people talk about, depending on what region they are, they get better services in some regions,
Yeah.
some regions not. Like, can you speak to any of that in terms of the struggle? Because sometimes families really talk about their frustration.
Yeah.
And you might have someone having a great experience and then totally opposite experience.
That can happen. That can happen because as LHIN, well, what they're trying to do is change that. They're trying to make care equitable across different sectors of Ontario. But traditionally, that didn't happen. So in Toronto, we have a large population, so we have more people, we have more hospitals, we have more health centers. So we, just by the sheer fact that we're in a big city, we have a lot more services and things that people can access. We have a lot more service providers. The way that different LHINs set up how they offer services is specific from LHIN to LHIN to LHIN. So what we do here is different maybe than what Central LHIN may do, but we're trying to realign some of that to make care more equitable. But it's going to take a little bit of time. But traditionally, you are correct. That some LHINs, so sometimes I was saying some clients will move into Toronto Central LHIN because they may be closer to their physicians, their service providers, their community health centers, so that does happen where care can be inequitable across the LHINs, but they're trying to change that. We're trying to also change and become more uniform with our assessments. So for example, if my client lives in Toronto Central LHIN and now they're going to go into Central LHIN, our assessments are the same. So you know that if I've already been assessed here, you don't need to redo it and do everything when you move up to York Region. So we're trying to also be on the same page for a lot of our assessment. A lot of this has taken time because it's really policy driven and model driven. So it's taken time, but it'll happen. But we're trying. Yeah, we're trying.
No burning questions, guys. Kim's here.
Yeah.
So as a LHIN care coordinator, what do you guys have, like a maximum caseload?
Not
Especially if
really.
you're transitioning into this new model?
So what they're trying to do, so if I'm a care coordinator and I have a complex caseload, they're trying to make our caseload smaller. Traditionally, when I was adult supportive care, I would have anywhere between 80 and 90 clients. Some of my colleagues, depending on the geographic area, so I have a colleague in the Thornhill Park area, she may have 110 to 120 clients. and a lot of them may be complex. So that's a lot of why we're kind of changing our model to try and make it not just less, but the quality of care and service that we provide better. Because sometimes you feel like you don't have enough time. Like you got to go and do a visit, and you got to go and do this service stuff, and then you got to go talk to this provider. So it's really trying to maximize what we can do in a smaller area so that we can spend more time with clients. What I found really helpful is partnering with providers, caregivers, community agencies. So if I need to go in and do a visit, I may contact the RENA caseworker and the PSW agency supervisor. So we're all going to do the visit at the same time. So it's easier for the client, and then everybody can kind of know what's going on. So I found that to be really helpful, partnering with different sectors. But our caseloads can be high. And it's really based on geographic area. So some areas we just get more referrals from. Downtown core, those tend to be higher caseloads. Different client population than my area. So downtown you would have more of a population that may be homeless, may have more mental health. Unstable housing. In my area, it's both. Like I have clients that may be well supported and have funds, and then I have other clients that are not so. But some caseloads, depending on the area and the population, can be larger.
You may have addressed this earlier on
Sure.
with regarding the PSW, but one of the issues we have is the schedule, their inability to stick to the schedule time that we have agreed to.
Yes.
I have one gentleman whose schedule should be at 8:15,
Yeah.
but sometimes they're knocking on his door at 7, at 7:30, when he doesn't expect them.
Yes.
And he's not.
And they don't necessarily not call him ahead of time.
No, they don't call ahead
Or
of
maybe
time.
the client may have deficits where they're not able to
Yes.
understand that for one
Exactly.
reason or the other.
Exactly. And
That does happen quite
Yeah.
often, and
Yeah.
that speaks to the nature of home care. So
Yes.
if his regular PSW suddenly quits or
Yes.
goes to another agency,
Yes.
that schedule may shift.
Or on
Or if
vacation.
the PSW goes away to the Philippines for a month,
Yes. Yeah.
that's a big shift.
Yes.
Those things are hard to control. We try and say we don't have time specific, but for clients that do need that time specific, we try our best. But just to be aware that there are going to be pulls on the system where it may not be that time specific may happen consistently. What you could do is check in with the coordinator, maybe on a monthly basis or every couple weeks, and say, okay, can you contact the agency and let me know, have they hired any new people? Is there anybody available now to go back to that 8:30 visit? Because the agencies are constantly hiring PSWs, so there may be availability in the future. But it's difficult to follow up on in a timely manner. So if you give those reminders to the coordinator to say, can you please check, then we can definitely do that.
Okay.
Or, like I said, you may have more than one agency. So if that agency can't provide that time specific or on that specific day, you may want to talk to the coordinator and see, can we have a different agency coming in on Monday, Wednesday, Friday at 8:30? That's always an option.
Okay. Good.
Just be aware, though, that they're having two agencies may get a little bit confusing.
Yeah.
That's
yeah.
the only thing.
Yeah, because we didn't expect that when we made the arrangement.
Yes.
Because we have a slot for us as an agency to fill in when that PSW leaves.
Oh, okay.
Because
Okay.
she's supposed to be there at 8:15, she leaves at 9, then my staff comes in at 9.
Ah,
But
okay,
when
I see
she
what you
comes
mean.
at 7:30, you have that huge
Gap.
gap when
Okay.
I can't call the staff in to come in
Is it because the client can't be by themselves?
for too long, yeah.
Ah, okay. That may take some more intensive case management, so you may
Yeah.
have to get that coordinator out there again and problem solve.
Yeah,
Because that seems like an issue that has to be addressed, because safety-wise, that person can't be by themselves.
Yeah.
So you have to problem solve and see what other areas can be explored to see where we can fill this gap. Yeah.
good.
So I would call the coordinator. Yeah.
Yeah, I think that there's a huge shortage right now with VHA and CBI and a lot, and I think that as service coordinators, we often see the LHIN as the gateway to the home care support, but really they're two separate issues. But they're the subcontracts where there's the shortage right now. I've recently done a few joint home visits with the care coordinator from the LHIN, and I found them really helpful. And I think that once you do a few of those visits, you realize all the other services that the LHIN can help coordinate through the healthcare system. For example, PRN protocol, we had a child who was going into respite. She needed the PRN protocol, but VHA needed one on their file as well.
Yes,
So that
we
was
have to
something
share
that our
those.
LHIN coordinator was able to help facilitate, which saved the family a lot of time because they didn't have to go to the doctor and, wait several months or weeks to get in, to get that protocol written, and it was something that the LHIN facilitator was able to facilitate, which was really helpful. So I think that there's a lot of resources that the LHIN can help with, and I think home care is just one small piece of it.
Home care, a lot of what we do is system navigation and trying to connect people and make it as seamless as possible or as easy a transition as possible. Some of the services that we provide, so you guys know personal support worker service, a lot of clients tend to be on that for a longer period of time because their circumstances are maybe chronic in nature and not change. Some people may be on it acutely, but most people are on it for extended periods of time. We have occupational therapy service, physiotherapy service, dietitian, speech and language, social work service. We have in-home lab service for clients that are homebound. So if you have a client that's not able to access a lab service in the community, you can contact the coordinator and see if the client would be eligible for in-home lab service. With occupational therapy, they do most often home safety assessments. So they will come in and do a full assessment of the client's home. If you think safety is an issue around things like meal prep or stove use, they can do that type of thing as well. They often will provide prescription for mobility aids, bathroom equipment, power wheelchair prescriptions. They will do applications to the Assistive Devices Program, ODSP, Ceridian Cares, other community funding agencies for that equipment. Physiotherapists will do a mobility assessment. They will prescribe a home exercise program. They may give education about falls prevention. They may also prescribe a gait aid, not so much the seating and the bathroom equipment, more so around like walkers, canes, crutches, those kinds of things. Our social workers do short-term counseling support. If you need longer-term case management or counseling, they will refer you on to an agency in the community that will be able to provide that. They do housing applications, so a lot of those housing, supportive housing, they'll do those applications. The coordinator may also do that application if they have time, but oftentimes it's social workers doing those applications. They can do Meals on Wheels, they can do referrals to mental health counseling. There's a really good agency called the Access Point. I don't know if you guys are familiar with them. It's really good. They're a hub agency. So for clients that may have mental health and addiction or need mental health housing, they will process those applications and link you to a provider in that area. So in the North York area, Loft is often an agency that they will refer to. They work with Griffin Center, lots of other different types of agencies as well. So they're a hub for clients that need mental health housing, addiction support, intensive case management. You don't have to have a formal diagnosis. You can be experiencing symptoms of things and they will also accept those referrals. So that's a really good agency. So that's social work service. Dietitian service could be for anybody that wants to gain weight, lose weight, diabetic education, maintain weight. I forgot to say that. That's often really an important thing for our clients.
But recently I requested a nutritionist because my client was losing weight.
Yeah.
And it's not, they don't actually come to the home. They give you this phone number and you connect through telehealth with a nutritionist. And she provides you with information of, what recommendations
Yeah.
of how to gain weight. So they would only come to the home if it was, I think if the person was homebound.
No, I have clients that are not home, but like, so, for example, let's say you already have a physician at Ann Johnston Health Station or at Unison. Instead of referring to our service, I may call that family health team or that community health center and say, do you have a dietitian service that the client can access? But if they're not able to be linked to an outpatient setting, then we do provide in-home dietitian service.
And
It is
this guy
short
was in a
term.
rooming house, and they weren't gonna come out to do a nutrition session.
I'm not sure why not. I'm not sure why
Okay.
not. I can't answer that one. But it'd be worth calling into the LHIN again.
There's
It'd be
yeah,
worth,
oh, sorry.
yeah, call into the LHIN again.
Okay.
Yeah, because it may be just that you came across
Yeah, I don't know.
a barrier
Yeah.
there, but I put in services for clients that may be homebound but may not be homebound.
Okay.
They do a lot of teaching for clients that may be newly diagnosed with diabetes. So how to manage their insulin, their diet, crises if their sugars get too high, get too low, those kinds of things. I have a couple of clients, one client in Bob Rumble, he gets nursing service for insulin administration, and then a personal support worker has that task delegated to them. So if it can be a delegated act where that group home may not be able to provide that support, then we can work and see, how we can better support them.
But sometimes it's difficult to access diabetes management in the home through nursing. Like I tried that with clients that have disability and are not able to do it, and their diabetes is unstable, and I guess
Did you
it
call
depends
into the
which-
LHIN?
Yeah, it was through the care coordinator. They wouldn't give it.
Hmm.
That kind of. It's not always easy to access those.
If you're ever having a problem, it may be that you need to maybe speak with a supervisor or somebody else, because I put in services for people that need that dietitian service if they can't go out to access it in the community, or for whatever reason. It could be a physical disability that makes them not be able to access, or it could be that they don't have transportation arranged, or it could be that it's just challenging for them cognitively to manage all of that. So I have put in dietitian service for people who need to maintain weight, lose weight, gain weight. They do education around feeds as well, especially for the pediatric population and the adult population that may have a new G-tube or J-tube inserted. They will work with those clients. Oftentimes, that referral may come from the hospital or a physician, because they may want a specific feed at a certain rate. So those kinds of things may need a doctor's referral for. Some of our services, we do need a doctor's referral. So if it's a nurse to do IV medication, we would need a doctor's referral. If it is for catheterization, we would need a doctor's referral. And then we would send all of those referrals and orders onto the service provider.
When we meet with a family and they voice their concerns about, their PSWs or whatnot, is the chain of communication to always redirect them to their care coordinator?
Meaning me, like at the LHIN?
Yeah. So that's all the support they're receiving is organized through the LHIN.
Yeah.
And, they have issues with the
Yeah.
PSW, say, and the PSW is actually, some subcontracted agency or whatnot.
Yeah.
Are you to direct the family back to their care
Yes.
coordinator, and if their concern is with their care coordinator, where do
You can
call
always
them?
ask to speak to a manager. That's always available. If you can't get anywhere with that particular coordinator and there's a concern, oftentimes if there is an issue with a PSW schedule or a routine, I will speak to that agency and I'll talk to the scheduling coordinator, or I will do a joint visit with the PSW supervisor that does home visits. And we will do the joint visit and figure out what's going on and how we can better support the client and resolve whatever the issue is. So we often try and partner that way, because it's easier to have all the players at the table. And sometimes with some situations, the issue can't be resolved with the provider, and you then find a different way. So that's always a possibility. Or you may add a secondary provider if whatever that issue is can't be resolved. So we try and find solutions, but I would link back with the coordinator, because that's part of our piece of care coordination, is trying to resolve those issues that can't be resolved with the client and the provider. For things like if you want to cancel a visit or reschedule it, or let them know you're going on a vacation. You can go ahead and just call the agency. If there's an issue you can't resolve, then I would go back to the coordinator. Yeah.
Is there a phone number that families can access, let's say, should they want to put in complaints if they don't want to necessarily go down the route with?
The coordinator?
Yeah.
So you can call the LHIN number directly. We have a client relations department. So you would dial the main number, the 416-506-9888. You can ask to speak to a coordinator's manager. That's also a route that you can go. So dial the main number. You can also let the coordinator know, and the coordinator should be following up with their manager to say, look, there's these issues that my client is experiencing. They may call you. This is the situation, just to give them a heads up as well. So there's different routes that you can go, depending on the situation. Yeah. But don't ever keep it, like always, we're always looking for feedback, because we don't know unless you tell us. So if there's a situation that's brewing, don't let it get too far out of hand. Like if you start to see, for example, issues with PSW service, try and get it resolved as quickly as possible, because it ends up being a poor experience for the client. So if you see that, if you see parents or clients experiencing that, then follow up with the coordinator as soon as you can. Yeah. Any other questions? Okay.
Thank you for coming. We'll be setting out, we have a new guest speaker next month, sorry. PG&T, I think we're gonna get.
Oh, that's awesome. I'm gonna come to that one.
Okay. That's been a work in progress. So we'll be getting that information out soon, so you can sign up.